everyone. My name is Tobias Mattei. I'm the deputy editor of NASSJ, and I have the privilege of having with me here Dr. Yi Lu. He is the director of the neurosurgical trauma at Brigham and Women's, and also the Spine Fellowship director. And he brought his whole team to discuss traumatic spinal cord injury. They published an article in NASSJ, which I can best describe as a simply like a tour de force in all aspects relevant to a spine surgery regarding spinal cord injury, from pathophysiology to timing of surgical treatment, rehabilitation. So I would say and encourage our listeners to download the paper. It's definitely a one-stop shop for you to get everything you need to know about the front edge of research in this topic. So thank you for being here, Dr. Lu, Joshua, and Ben.
Thank you, Dr. Mattei. Just for the background, so this paper is essentially a section report. So I'm also the co-chair of the spinal cord injury section at NASS, and this is the section report. All of our section presented papers on the most updated advancement in the field, and in our field is the spinal cord injury.
And we have some also well-known co-authors. I mean, Dr. Michael Feelings is a co-author of this paper, so it gives a lot of credence to whatever you're discussing. Is definitely something that is the position of well-respected figures from this field. So let's start with the how you performed this. This is a narrative review. So tell me how you went about to kind of doing this, finding the relevant literature and addressing this topic. I mean, a paper with 270 reference. It's definitely something that I'm sure you had some methodology of how analyzing such a wealth of data.
Yeah, it's very extensive paper. And then Josh, you want to take up on that?
Sure. Basically, we had we did an extensive PubMed research, and we listed all our keywords there. We ended up with like 1,000+ articles. We obviously, as you can see, have a lot of co-authors on the paper, which also helped us sort through all the articles that we got back. But we tried to focus on high quality articles, so like systematic reviews, meta-analyses, clinical trials, and some of the more leading preclinical research in animal models. We tried to avoid as much as possible some of the more like smaller impact animal papers that might not be directly relevant towards the clinical practice.
So I think we could go kind of stepwise through the subsections of the paper and start with the management of spinal cord injury, acute traumatic spinal cord injury, and maybe we could divide that in pre-hospital care in terms of all you want to highlighting the goals for blood pressure, and then of course a big topic is the timing of spinal cord injury. So I mean, go ahead, let us know what you found on that.
Yeah, so we also included a lot of experts in the field of spinal cord injury. We want to cover both the most advanced, the area for the essentially the guidelines for the peri-operative care. So the recent the AO spine and the practice guideline for that have 3 areas. One is the timing of the surgery, the other is cardiovascular management, and the other is intra-op spinal cord injury. So we want to include that as our essentially perioperative care of the spinal cord injury. So that's one major part. Dr. Feelings, of course, is a major part of the guidelines. And on the other end, we also want to include all the most advancement in the field of spinal cord injury research. I will talk about that in a little bit.
So let's focus a little bit on the blood pressure goals, because I know every meeting that there's a big discussion on that, and I think it seems to be settled on a certain range, even though the evidence may not be that great for that. I get the point that, and please correct me if that applies both to preoperative as well as intraoperative, but it seems that a MAP goal of 85 to 90 seems to be the best recommendation. Am I correct on that?
So the guideline, the previous guideline from NASSJ, and we still follow that, is the 85 to 90. But in practical, we realized, and for 7 days, and then in practical realized this guideline is very narrow. So the MAP goal is too narrow. Sometimes it's very hard to follow. and whether it needs 7 days or not, that's kind of empirical. So we, the AO Spine and practice, we essentially did a very extensive literature research again, and come up with a slightly wider parameters so that the practitioners can have a little more freedom in terms of the blood pressure and then timing wise. So essentially, you just want to avoid the hypotensive episode, and you don't necessarily need to go up to 85. I think the lowest is 75 to 85, and the highest somewhere 95. You just want to within that range, and for 3 to 7 days. So the new guidelines give a lot more freedom for the practitioner to not to be stick to very narrow range.
Okay, that's very interesting because yeah, I was familiar with the NASSJ recommendation, and I agree that that approach is very wise in terms of even medical legal issues and litigation, right? I mean, you can imagine how hard it may be to keep the with a patient with some other abdominal injuries or even intraoperative when you're inducing the patient, and lo and behold, your pressure drops to 80, and some attorney comes with the argument that the NS and CNS guidelines recommended 85 to 90, and for about 30 minutes you deviated from that accepted standard of care. So I do believe it's a very wise approach. 75 to 95 seems very reasonable. In our institution, we're still using the 3 days. But I agree. I mean, having some leeway in deciding that, both in terms of, I mean, your ICU utilization, and I know some surgeons are always concerned about the risk of perioperative bleeding because you're keeping the patients under hypertension. I never had that issue, but no, that's very interesting. Let's talk about steroids. I mean, I think, I mean, since that the NASSJ guidelines that recommended against the use of steroids almost a decade ago, I think we're settled on high-dose steroids recommendation against that. Anything different regarding the use of steroids, which during my training was a big, I even memorized the whole protocol for methylprednisolone.
Yeah, so the steroid is definitely a controversial point still, and essentially the guideline, the new guidelines also give a lot more freedom to the practitioners, and because the data didn't support either, there's some pros and cons, and the new guidelines give the steroid it's definitely an option for the treatment, and but it's not a requirement for sure. And in my own practice, I use low dose steroids. I believe it's beneficial with less side effect. But there's some very good data on using the steroids for at least HSC patient. You just need to try to avoid the complications, so avoid extremely high dose steroid.
And that's very interesting because, I mean, even again, considering matters of litigation, I mean, if you have a guideline with a level 1 recommendation against, I think, I mean, everyone from that point on really stopped using steroids. And I remember going to the meetings, and I think it was Dr. Fillings or some other practitioner say, hey, I still consider steroids for especially pediatric patients or in HSC. And I was quite surprised about that. So I understand you don't, I mean, the position now you're saying that there's no evidence, but you're not making a formal recommendation against, especially when considering low dose. So, I mean, that's very interesting. Let's go to operative management. I'm a big fan of early and even ultra early. I'm one of the most aggressive spine surgeons in our team, and it's very refreshing to go to the meetings and see Dr. Fillings saying that there's no central cord. I mean, it's a broad spectrum of incomplete, and even though some patients may benefit only from observation, it's very harmful to the patients to just label the patient a central cord and book them for 7 days down the road. You may be really hurting some patients with incomplete spinal cord injury. So, I mean, we have Staskis, which is the best evidence, and I think it's going to be hard to go anything more than that. I mean, we're not going to be able to randomize patients. So I think for the decades to come, that's going to be the best evidence we have with a deadline of 24 hours. But let's discuss a little bit about the literature on ultra early, because that makes sense from from the pathophysiology standpoint, and at least my position on that, I discussed with my residents, said, unless you have a good reason for not taking the patient at 3 a.m. to the OR, either because the patient is hypotensive or something else, you should be doing, because you're not offering any benefit, and you're going to incur the same surgical trauma. So unless there's something very meaningful that you could wait and the patient would be in a better position to undergo the surgery. So what did you find about ultra early intervention, less than 12 hours, or even some studies 6 hours?
Yeah, so there's no strong, at least for now, there's no strong data to support the ultra early, but it does probably just because of the amount of patients and the available data on it. And also, same thing here, we gave the practitioner a lot more leeway, and because everybody is very concerned about medical legal aspect. And you also need to balance the medical condition of the patient. Like you mentioned, if the patient is medically not suitable to have surgery early, you do want to take that into consideration as well. So essentially, the recommendation is try to do the surgery as soon as you can within 24 hours if the patient is medically suitable to do that. And there's no strong data to support ultra early, but in our own practice, we definitely believe the early the better. And also we need to consider we are in the tertiary care center, so that not everybody have very early access to the tertiary care center. We need to take that into consideration. People that may need to be transported several times to get the needed care. Essentially, the earlier the better, but to the level that medically feasible. So.
I mean, the logistics of getting surgery within 6 or 12 hours is really challenging, right? From the injury, patient arriving to the hospital, getting the initial trauma assessment, probably getting a CT scan of chest, abdomen, pelvis, everything, and then you call for the MRI. It may still take an hour or two, even if you level as a 2 in the OR, it's still a few more hours. So it's good to have that leeway and not having that pressure, but at the same time, having in mind that, I mean, you're not delaying and posting as the first case in the morning unless there's a good reason.
Yeah, and then also another part which we are probably gonna do a little bit more study on is the central cord syndrome, or more the incomplete spinal cord injury that without fracture dislocation. So that area is still not clear, and we're still gathering more data. We may NASS and WNS CNS, we probably want to come up with we're planning to come up with a joint guidelines of the central cord syndrome guidelines, and the data has been suggesting for those type of patients, HSC central cord patients probably still benefit from early surgery within 24 hours. But for a milder patient like HB or more severe patient that may need a little more time, may be okay.
Yeah, I think that, I mean, central cord timing for central cord, it's probably one of the most controversial topics in spine surgery. And I think the wisest approach I found on this is to divide those patients with fracture dislocations, which we know probably they're just some type of incomplete, they are unstable. And then I think there are two groups, and correct me if you see the difference, but there are the central cord with ongoing compression and a signal in the cord. And that group of central cord where you may even see a signal in the cord and you still see CSF around the spinal cord. There was an injury, but I mean, it's hard to decompress what's not under compression and argue that you're making things bad. And usually those are the patients that have only hyperesthesia and they have no motor deficits. Does that make sense, that dividing them in patients with ongoing compression and those with...
Absolutely. And then we should definitely separate the patient with instability, with fracture dislocation, with the patient with same incomplete spinal cord injury, but with no fracture dislocation. So that's a very, very two different group of patients. And the same thing with you mentioned the patients with no ongoing compressions, and usually those patients will not be in the HSC category. They will be in the much milder symptom categories, and those patients generally they may not need surgery surgery at all. So or can require a little bit time of observation before surgery. So that area is definitely in the active research area, and hopefully we'll come up with a guideline to give us more guidance soon on that.
And we've all seen the type of patients. I mean, they come, they say, doctor, I was paralyzed at the scene. I could not move. There's documentation of that. By the time you see them, they're already moving everything, but they have terrible hyperesthesia and no ongoing compression. You put them on high dose Lyrica, and after a few days, they already see some improvement. And in a few weeks, you follow up and they're fine. So let's talk a little bit about prognostic factor. You discussed about imaging biomarkers as well as molecular biomarkers. What novelty do we have regarding that in terms of extent of TTC, extent of signal in the cord, in the tissue image, or biomarkers? What are we looking at the clinical practice in terms of prognosis?
Josh and Ben, guys want to take on that?
Sure. So I think I think one section, though, that it might be nice to talk about as well is maybe going back to the CSF diversion and covering that a little bit as well. But yeah, I mean, there is limited evidence in terms of serobiomarkers for long-term outcomes. It's one of the things that would be nice to include in larger multi-center trials, just to be able to back up some of the initial imaging characteristics with what we're seeing in terms of axonal damage.
Okay, so let's go back because I think we missed something that, I mean, in every meeting is something that I believe there's a potential, which is not only CSF diversion, but monitoring of perfusion pressure. And that makes sense. I mean, we don't treat traumatic brain injuries just based on blood pressure. We treat them based on the differential between intracranial pressure and the mean arterial pressure. So what is the evidence and how do you see the future in terms of investigation and randomized trials in terms of the benefit of monitoring, first in terms of monitoring, tailoring your treatment to an ideal perfusion pressure of the spinal cord, and second, the possible benefit of even having some diversion of CSF as a means of reducing that intrathecal pressure?
Yeah, this just seems like a very good management strategy, just in terms of, initial stabilization, decompression, and then limiting some of the secondary effects of having a patient with very labile blood pressures, a lot of positional changes, and then several days where, titrating to just a MAP goal is really not very sophisticated when you think about the amount of swelling that's going on as secondary injury cascades happen in the cord. So it makes quite a bit of sense to have that constant monitoring. In terms of the studies that we've looked at, whether or not it was a constant CSF diversion versus and so you're essentially draining a certain amount of fluid per hour versus just opening when the cord perfusion pressure was too low. In the early results of that trial, it seems that just constant drainage was a better result, to not have somebody, nurse titrating essentially to once you got to peak, a perfusion issue. But there's issues with controlling how much CSF is drained between those two groups. I would say at MGB, we don't have that this isn't really part of the practice yet in terms of having ICU nurses really ready to go with lumbar drain management for cord perfusion pressure. But it's something that we're trying to implement. Is this something that you guys are doing regularly, having a lumbar drain and titrating to cord perfusion pressure?
We're not. I mean, we've seen the studies. There are some multi-center studies. I have some colleagues involved in that. And one of the things that I'll be curious, and maybe you went through all this literature and you're able to, I see the rationale of titrating for perfusion pressure, but there's a big difference when you're treating traumatic brain injuries. There's a good reason why you expect intracranial pressure to increase based on the Morrow-Kelly's laws and the limited space, even when you have a decompressive craniectomy. Before assuming a benefit of the benefit of CSF diversion, what is the data that we have? Because this is a treatment for patients after surgical treatment. So, you're not gonna treat the increased pressure around the area of compression. So you did your decompression. You have to assume that your CSF that you're monitoring is exactly the same pressure at the level of the injury, that everything is flowing adequately. What is the evidence that even if you experience some refractory swelling beyond, the level that, some people speak about duotomies, and there was the whole concept, but beyond whatever the space from the thecal sac can support, what is the evidence that reflects into the intrathecal pressure is measured by a lumbar drain with the tip of the lumbar drain around the level of, let's say, L1?
Yeah, I have to say the evidence is still weak right now on that part. That's actually the major criticism on my part as well for the lumbar drain. Essentially, whether you're measuring the intrathecal pressure, whether it's reflecting the intraspinal cord pressure at the area of the spinal cord injury, essentially nobody's clear on that. But there is evidence of that draining spinal fluid probably can provide certain benefit for the patient, whether it's through the decrease of the intrathecal pressure. I think the whole area still requires a lot more research and a lot more guidance in terms of whether it's beneficial, how to make it beneficial, what number to follow, and whether you're just following the number of CSF drain per hour, or whether you follow the intrathecal pressure that you monitor from the lumbar drain. I don't think that's clear yet. We're waiting for more data on that.
What about duroplasty? Because I remember this being something probably explored 30 or 40 years ago, and then it was something completely almost unacceptable. And then one of the main discussion recently in the NASS meetings was say, hey, I mean, this may not be a bad idea of exploring the concept when in the setting of increasing the intrathecal the spinal cord perfusion pressure. So using that as a way to determine those patients who are experiencing refractory swelling despite the laminectomy. And we all seen those cases. I mean, you see a T2 signal in the cord growing from post-op day 1 to post-op day 3, and no CSF around the spinal cord. Is there any ongoing study on that? And do you see that as something that is potential?
Yeah. So several people, including our co-chair of the spinal injury section, Dr. Rajesh Saigal, which is a co-author on the paper as well. So he has been doing some study on duroplasty for the spinal cord injury patient, and also including lumbar drain studies as well. So I have to say the data, that the evidence is not clear yet for sure. And in my own practice, I do use ultrasound to check, make sure after the decompression, there's CSF around the spinal cord. If we see a pretty good decompression with the CSF around, I may not do the duroplasty. But if it's still tight and still swollen, then I think I will do it. But again, that's just my own practice, and whether it should be universally done, it's unclear.
I don't want to miss the topic of pharmacological treatments, and especially those focus on neuroprotection. I know there's I would say for the past 20 years, so many studies demonstrating the efficacy of so many medications. And I think the last study we had, it was Dr. Fillings presenting the results of the riluzole trial. And according to him, it seems there was an unfortunate situation where the COVID really impaired recruitment. And I mean, I had a question that I hate speaking about approaching significance. There's nothing, I mean, the null hypothesis significance test is all or nothing. So it's either significant or not significant. And I mean, those are the rules of the game. But I mean, in terms of a power analysis, I mean, he was mentioning that if they had a handful of additional patients, or maybe 10 additional patients, very likely he would have reached the threshold to have that as the standard of care. What do you see? I mean, do you see a future trial again on that, or what do you see in the future? We've not had any pharmacological treatment for this in the past half century, right?
So riluzole, Dr. Fillings, I think he also did some secondary analysis of the data, and did reach a statistical significance, and on some of the subgroups of patients, and also in practice, and people have been doing more and more of the have been using Riluzole and even for cervical patients with severe cervical stenosis and with decompression. Sometimes people felt that may decrease the chance of C5 palsy. But again, this is the area that's it's all anecdotal right now. It's
In the setting of myelopathy, so that's what you're saying?
correct. Yeah.
Can you see, because I mean, a lot, sometimes, I mean, our guidelines, I mean, we always strive for level 1 evidence and randomized trials. I mean, I think it's going to be hard to repeat this trial, but can you see or envision in the future, maybe 5 or 10 years, this being part of the guidelines based on a risk-benefit analysis? It's not a medication with a high risk. The cost is reasonable, and there's enough clinical evidence to support the use, even though you may be something that you leave at the discretion of surgeon, not like we did with the methylprednisolone that we established that everyone on earth had to do that. Right. Otherwise, they would be in legal trouble.
Yeah, maybe I don't know exactly what the direction is going to be. So maybe with more practical use in the real life situation, and people can do a little bit more retrospective studies. And on the one who has used the Riluzole, yeah, it's going to be. Hopefully, there will be more prospective trial. All those trials so expensive and so difficult to do.
So let's discuss a little bit about the topics that I think most patients are interested in, and they always ask about, say, hey, what about neuroregeneration? And I can tell you we're publishing a paper that is coming up on JNS Spine in a few months on Christopher Reeve's injury, and we're basically relating some of the historical facts of his injury. I mean, it was interesting. He was treated several days after the injury, and even with that, he recovered. Of course, at that time, we used steroids. But the main thing we found is that he was a big advocate, even in terms of the refoundation for embryonic stem cells. And I think early 2000s, people thought, and I remember I myself did some research with umbilical cord stem cells when I was at the University of Illinois at Peoria. And I have the impression, and please correct me with your expertise, that, I mean, the pathway forward is definitely, I mean, every single study that tried to employ stem cell in some sense, either to improve the environment around the spinal cord, decrease inflammation. I mean, you have the issues with the site of injection. You may cause a trauma just by injecting it into the spinal cord. I remember there was a trial when I was still in Brazil that they were doing endovascular delivery through the segmental arteries, which seemed like an approach. But at the end of the day, I don't remember any clinical improvement or even any evidence that those stem cells, they really could be identified later as being inside the spinal cord in any meaningful way. But I see a big prospect for neuromodulation. And I do a lot of spinal cord stimulations for pain, but I mean, I think for the past 5 or 7 years, we've seen some protocols, especially in Europe, with brain-machine interface, and you have those electrodes in the motor area, and they're connected to a paddle lead below the level of the injury. And the main challenge, of course, is how you decode the brain inputs and try to make them into a smooth contraction of several different muscles to the point of enabling some gait. I mean, the results, we've all seen pictures of patients who were fully paralyzed, and now they are walking with a very unsteady gait and very problematic on parallel bars. So that's pretty impressive, but
yeah,
tell me
and
that's the future of.
The patient series for those are obviously very small. It's very high intensity PT and then neurophysiology to tune the stimulation parameters to maximize whatever the residual function is that the patient has, or to basically unlock the motor pool from whatever you're getting from the brain machine interface. And I think, I mean, Josh and Dr. Liu can speak for themselves, but in general, the bet versus of trying to regrow a very long segment, through an injury and doing cell transplantation to augment that regeneration or at least decrease the inhibitory signals is not probably as quick to having a big impact as figuring out better neuromodulation schemes. So we are also in that kind of pool that, if possible, getting the paddle placed correctly, getting the stimulation and better patient selection is probably going to be a quicker route to having more patients treated. Again, it's like 9 patients or so between core teen and block, and a few other groups looking into it, but that could ramp up quickly if really there's a better way of protocolizing the patient selection and the neurophysiology team that needs to optimize the stimulators.
So we're talking about 2 very exciting areas of the spinal cord injury advancement right now: the neural regeneration and the neuromodulation. So for the regeneration part, there's a lot of science going on. I do have to say the stem cell part would definitely need more research, more study in finding out the mechanism, exactly whether it's safe, whether it's effective, and a lot of stem cells effect you see it is from the neurotrophic factors released by those cells instead of regenerations. And that being said, then why can't we just give the neurotrophic factors to the so there's a lot of research going on in terms of neuroregeneration. So what's the best strategy to help the nerve to grow, to regenerate? Potentially, let's deliver the neurotrophic factors direct to the spinal cord injury site and see whether that can be effective. And there's a lot of basic science data on that. In terms of, and then there's a lot of studies on the scar tissue, with how can we create an environment for the nerve to generate much more easily, and that's a very, very active area of research. People probably don't know that, for example, for the neonatal mice, if you create a spinal cord injury, they actually repair the spinal cord injury very, very effectively. The difference between that when with adult animal or adult human is that the amount of scar tissue formed at the injury site. So so that's clearly a very can be a very, very interesting and very active area of research, and potential has future clinical usage. In terms of neuromodulation,
let me ask you one question on that, on the neurogeneration, before I go to neuromodulation, because I mean, one of the questions that I've always had is, what is the best method for delivering whatever therapy you have? I've seen all those protocols of direct injection upon the spinal cord injury and the formation of cavities, and it is a problem. I mean, you take a spinal cord is already injured and inject 5 cc's or something around that. I thought the potential of delivering endovascularly was something. Some people have thought about the idea of intrathecal delivery of some factors. How do you see the best method of delivering whatever type of therapies we want to, in terms of either neurotrophic factors or stem cells? What's your impression on that?
Yeah, we in our own lab and my mentor's lab, we have done a lot of research also on the way of delivery. In terms of this can be quite a bit virus. For example, we have a virus that can essentially cross the blood spinal cord area, a barrier after within 7 days of injury, and specific express the virus at the injury site. So that's a potential. One way to do is to do the intravascular delivery and has a virus cross the blood spinal cord barrier and express only at the spinal cord injury site. And there's also ways of, for example, the low intensity ultrasound can help open up the blood spinal cord barrier as well. There's ways for spine surgeons, like when we do the surgeries, there's potential ways we can open up the spine, the dura, and deliver the agent at the site under control without putting pressure on the spinal cord. There has been effort on creating scaffold, place a scaffold at the area of the spinal cord injury where the cavity will form, and the data is mixed, and there's potential, but there's another potential way of creating that environment for more beneficial environment for the calm down, decrease inflammation, help the regenerations. There's a lot of study in China as well. They use certain type of material to help down that part as well. So.
I think you mentioned something that I never thought that much about it, but it seems a very wise way, especially because all these patients probably would be operated, to explore methods of local delivery through, sustained release of whatever you have through some synthetic material like a gel foam embedded with something that's going to release that for the next 5 or 7 days until it dissolves. I mean, that doesn't affect the integrity of the spinal cord, and at the same time, it probably does the job for that period where the scar tissue, where things really matter, which is very early stages, maybe in the first 7 days. And it wouldn't change that much. I mean, you're already doing surgery, so besides a dural opening and laying layer of tissue over the spinal cord with the drug or the virus system that you're delivering, that seems a very interesting approach. And so I interrupt you, I'm so sorry, about the neuromodulation. Tell me your intake on that and how you see the future of neuromodulation.
Yeah, I think neuromodulation is definitely probably the most exciting field, the active field within the spinal cord injury advancement right now, because there's so many data and excitement on that. We definitely see a lot of case reports, essentially, reporting the improvement of motor functions, and actually more surprisingly is the improvement of the cardiovascular and urological functions for those patients. And a lot of time it's not the expected outcome, but it's actually the surprising outcome, the patient doing so well after the spinal cord injury stimulator placement and epidural stimulator placement. They have greatly improved urological and cardiovascular functions afterwards. And in terms of motor function, that's probably the most complicated area to improve. That's why it's hard to see the immediate result, but we definitely has a lot of case reports showing that. There's a lot of questions in that area as well. Exactly what is the mechanism of epidural stimulation improving the motor functions? It's still not very clear. And what's the optimal parameters of the stimulations? And what's the whether it's important to have a feedback, whether it should just be a constant stimulation or whether it should be a feedback constant stimulation. It's also not clear yet.
Do you see these neuromodulation techniques bypassing all the promise of the exoskeleton? And I still go back to I think it was the World Cup in Brazil or maybe the Olympics, and there was a researcher there. He was actually from a med school, and he's in a lab here in the US, Nicolallis. And basically, he had a patient who was fully paralyzed, HIA, and with brain-machine interface. He had like a huge something mounted on him, and he was able to kick the ball. And I mean, you look at that and you say, hey, I mean, it's almost a chair that he's inside there and he's trying to move that. And when I saw those papers coming from Europe, maybe 5 years ago, starting with patients having, even though that very spastic gait or uncoordinated, what's your impression? Do you think there's still going to be a role in the near future for the brain-machine interface using exoskeleton, which patients always ask, say, hey, if I cannot walk, I mean, can you put me into something that I can ambulate? Or do you think that we're going to be able to bypass that and offer, at least for the incomplete spinal cord injuries, this type of brain-machine interface coupled with direct stimulation of the spinal cord? What's your impression?
Yeah, I think it's actually exciting that there's so many fronts in the spinal cord injury area that can potentially help the patients. They are all the fronts that are competing with each other, but they're also collaborating, like the neuroregenerations, the epidural stimulations, and exoskeleton. They essentially they work toward the same goal, but have different target, different angle of attack for the same problem. And hopefully we can find all the ways together to essentially collaborate together to solve the problem. But yeah, exoskeleton with a brain-machine interface is definitely a very, very promising field. And then we have, as mentioned in the Brigham, we have a brain machine BCI center that's working on certain aspects of that, and essentially we can potentially have the BCI brain computer interface to control the exoskeleton or control the epidural stimulations, or a combination of both, and try to give the patient as much function back as possible.
One thing that we have not addressed, and I don't think you had much in the paper, but it's something that it's always good reminding me that there are several centers focusing on, especially for patients with incomplete spinal cord injury, on nerve transfers to try to achieve whatever desired function. And we know like biceps or being able to feed yourself. So that's definitely something that, I mean, we're not talking directly in terms of neurodegeneration of the spinal cord injury, but in terms of restoring the necessary function through other means. Do you have any comments on that?
Yeah, Dr. Johnston is the expert on that.
This is a very interesting area, and for upper extremity function, having any residual function and transferring it to the muscles below the zone of injury is obviously a very good strategy. Dr. Brown at MGH is really the expert on this and has, pioneered this for years. The issue, and as you point out in kind of the neuromodulation options, is that for lower extremity function, this is just really not something that anyone can do. So maybe having a dual-pronged approach where you have some combination of nerve transfers and neuromodulation in the upper extremity, which we have filed an IRB to do and have registered with clinicaltrials.gov to go down that path. But then for the lower extremity, I think, as Dr. Liu pointed out, it's really more likely that this is going to be a direct neuromodulation approach. And in your comment about the exoskeleton, when you have an internal neuromodulation approach, you have both the benefit of the physiologic activation of the residual motor pool. So this may be beneficial for the patient to kind of keep muscle mass and have that be internal as opposed to having an external force kind of moving their joint through space. So that may be a benefit for the patient kind of in the long-term health, that they're actually activating motor groups still from having a neuromodulation system placed.
Perfect. And one of the things that you're mentioning about lower limbs function, sometimes we focus so much on motor function and we forget that sphincteric function is something that significantly affects the quality of life. And I remember, there's several urology groups that, especially for patients with partial function or retention, they use those sacral nerve stimulation devices. There was even some research, I think it was mainly in animal models, of transfer of the sacral rootlets and to try to restore, especially to improve urinary retention. So that's definitely something to keep an eye on, because
we're about to put out a paper that did a human transfer. So basically some residual lower extremity function was transferred in to the nerve directly innervating the bladder. So the patient had some residual lower extremity function and was able to activate the bladder. So that's coming out. But that's a one patient anecdote. It's a very limited patient population, not broadly, applicable to most SCI patients. And as you point out, some of the implants above the sacral roots, the Brinley machine and other options, these did not have great outcomes and had some of the infectious risks of patients who are not moving much, developing ulcers from, and having wound breakdown, and then having these systems explanted. So this is not, as you know, like a widely adopted strategy for bladder.
Yeah, blood, like I mentioned, that the neuromodulation is actually potentially a great way for the bladder and bottom bladder functions, and because a lot of it also involves spasticities, and so epidural stimulation is one way of neuromodulation. There's a lot of other potential ways, and Dr. Chalif, you may want to comment on what potential can be available for neuromodulations.
Sure. Yeah, there's, like Dr. Liu said, epidural stim, like epidural electrical stim is probably the one we know most about, coming, as everyone knows, out of Gregoire Courtine and others. Transcutaneous electrical stimulation, so the placement of the electrodes right on the skin, not requiring surgery. Also, there's a lot of work on that. Magnetic stimulation is a little bit newer, but there's some work coming out of Japan showing that we can activate some of the circuitry in the spinal cord using magnetic stimulation. So these are just some, and then you could even add things like, this is a little more in the lab at the moment, but like optogenetics, chemogenetics, sonogenetics, these types of things. So these technologies allow you to introduce ion channels to neurons to allow them to be responsive to whatever sort of modulation you then want to put onto the spinal cord. So we're a little bit away from that in clinical practice, but that's something that may be down the road.
Okay. So Ben, can you please forward me your paper whenever you
Yeah,
publish that? I'm very curious about and satisfy a little bit my curiosity in terms of what in that specific patient, what is the mechanism to activate the bladder? Because the previous study that I've seen in animal models, it was a cutaneous nerve, and basically by rubbing the lateral portion of the rat's thigh, that's how you would empty your bladder.
yeah.
How would it end up in your patient?
That's the JOW procedure, which was kind of difficult to replicate when it was rerun by a consortium, I think at Hopkins and Duke. And then this was a direct motor transfer. So the patient had volitional function in the medial compartment of the thigh, so the obturator. And by directly coapting to the vesicle branch running to the bladder, the normal receptors that are going to motor end plates and skeletal muscle were just flipped for smooth muscle innervation. So when the patient brought his two legs together and activated what was previously the medial compartment of the thigh, that allowed acetylcholine to be released around the bladder, and that was allowed for the contraction. So this is just accepted into neurosurgery and soon to be publicly out. And this Dr. Brown was the senior author for this.
Okay, that's very interesting. Anything else you would like to highlight to our listeners? Again, I encourage everyone to go there and spend your time going through this tour de force in terms of update in every single aspect of traumatic spinal cord injury. I can tell my residents that, hey, basically everything you need to know, it's in this paper. I mean, there's more that is not there, but you have a pretty good grasp of what's going on and the current status by going there. So again, I encourage our listeners, but anything else you would like to highlight or any final message?
Yeah, no, the final message is I think we're in a very exciting time for spinal cord injury research, and I think there's a lot of very, very promising field we're aiming toward the same goal to help patients recover the spinal cord functions and to make it even broader, so we know with brain surgeons and have the functional field. So we are making an effort to creating a spine functional field, and the spinal cord injury research and spinal trauma, that's all a big part of that. And I think the spinal functional field is going to be an important field in the future.
Okay. Josh, Ben, and Dr. Lu, thank you very much for your time. And I enjoy a lot this conversation, and I'm sure our listeners would significantly benefit, and a lot of them will be led to read your paper. And thanks for submitting to NASSJ.
Thank you, Dr.
Thank you.
Thank you.